Welcome back to the deep dive. Today, if you are anywhere in the high-stakes world of healthcare, this is for you. Whether you're leading a team right now, maybe you're preparing for that next big leadership leap, or you're just trying to figure out why the demands on clinical executives feel, well, almost superhuman these days.
We've built this deep dive specifically for that. Today, we're essentially opening up the blueprint for 21st century nursing leadership.
And it's so much more than clinical skills.
Oh, absolutely. This is about mastering strategy, finance, organizational chaos, and maybe most importantly, your own emotional toolkit.
That's a really good way to put it. The modern nurse leader. They're arguably the most essential strategic pivot point in the entire system.
They have to be.
They need to be powerful, clinically sharp, and, financially literate all at the same time.
And to figure this out, we've pulled a whole stack of sources that really map out this transformation.
Right. We have everything from those high-level foundational policy reports, the ones that literally change the profession,
All the way down to the granular, hands-on practices like developmental coaching and mindfulness.
So our mission today is really clarity. We want to pull out the essential knowledge that prepares a nurse to step into this incredibly complex future.
And to step in equipped not just to manage, but to really transform how care is delivered.
And the urgency for this, this wasn't decided last year. It was set in stone over a decade ago. We have to start at the foundational moment, right? The Institute of Medicine's huge 2010 report, The Future of Nursing.
That was the big bang. It really was. That report was the thing that demanded this professional evolution.
It put it all on the table.
It did. It fundamentally underscored this imperative for nurses to develop a significant leadership presence, a real visibility across all sectors.
Not just in the hospital.
Not just in the hospital. It declared that the profession must transform itself to meet the intense complexity of 21st century healthcare. It was a formal national acknowledgement that the old models just weren't going to cut it anymore.
So if the system is changing so dramatically, what kind of leader are we actually talking about? Because it's so far beyond just managing a unit now.
We're talking about individuals who have this profound combination of power, competence, and confidence.
Right.
They have to be capable of interacting as equals with this huge variety of high-level stakeholders.
So who are we talking about?
Think about it. Healthcare CEOs, major business leaders, federal and state governing agencies, and of course, the behemoth of the insurance industry.
Yeah.
This report didn't just suggest a little professional development. It catapulted the need for these advanced skills right into the center of the national healthcare reform dialogue.
So you have to be fluent in policy, finance, and patient outcomes all at once.
At a minimum. That sets an incredibly high bar.
Okay, so let's start by looking at the environment. What is actually fueling this transformation? What are the external forces shaping the job for a nurse leader every single day?
Well, if you ask any executive today, they'll boil all that constant pressure down to three objectives.
The big three.
The big three: improving quality, enhancing safety, and delivering demonstrable value-added care. These are the relentless drivers.
But those pressures themselves, they're driven by even bigger, accelerating external shifts, right?
Exactly. Let's unpack those.
Yeah, let's do that.
Our sources point to four key drivers that are essentially moving the goalposts faster than ever. First, you have these dramatic shifting population demographics.
The aging population.
The aging population, more chronic, complex conditions. This requires a radically different model of care than we had 20 years ago.
Sure.
Second, the relentless advancements in medical technologies, personalized medicine, sophisticated diagnostics. It all increases capability, but also complexity.
And then you have the patients themselves.
Right. Third is significantly heightened consumer awareness. Patients are educated, they shop for care, they demand transparency and outcomes.
And the fourth driver, I feel like, ties all of those together. It's that nonstop demand for high-quality, cost-effective care.
Precisely. And those forces mean that the organizations themselves have to be fundamentally restructured.
You can't use old tools for new problems.
You just can't. You can't solve these dynamic, multi-factor problems with outdated, rigid structures. The sources all emphasize this need to move swiftly away from the traditional hierarchical, bureaucratic, insulated models.
So a nurse leader isn't just managing the complexity of the patient anymore. They're managing the organizational shift required to handle that patient.
Absolutely. The real need is to move toward greater flexibility and, frankly, the ability to deal with acute ambiguity.
Ambiguity is the new normal.
It is the new normal. Organizations have to be structured to anticipate and deal with futuristic change, not just react to the last crisis. That organizational shift is inseparable from effective leadership.
And when we talk about this mandate for transformation, we have to confront the big reason why, the
Right.
safety crisis. The statistics on unsafe medical care are, they're frankly shocking.
They are truly staggering. It's a point that should demand our collective attention. Unsafe medical care is consistently cited as the third leading cause of death in the United States.
Right behind heart disease and cancer.
Right behind them. We are talking about estimates that range from 200,000 to 400,000 American deaths every year from preventable harm.
Just imagine that scale.
Imagine it. If a new public health crisis resulted in those numbers, the government would mobilize every single resource immediately.
And yet, because this is often tied to systemic issues, not a single disaster, it just kind of fades into the background noise.
It does, even though the financial cost is also just enormous.
What are we talking about financially?
Adverse events. They aren't just a tragedy for patients and families. They are a massive financial drain. They cost Medicare alone approximately $2.8 billion per year.
Billion with a B.
With a B. And what's so profoundly frustrating is the consensus that about half of these adverse events are preventable.
Half, that figure. That 200,000 to 400,000 preventable deaths. That's the most compelling argument possible for needing skilled, transformative leadership in nursing.
It is. But there are success stories. We have to point those out.
Right. Focused improvements do work.
They do, and we have to emphasize them to show that change is actually possible. A great example cited in the sources is the significant 44% reduction in central line infections.
That was between 2008 and 2012.
That's right. And how did they do it? Not with some miracle drug. It was by implementing a standardized 5-item checklist.
So simple.
Simple, combined with leadership commitment and systems improvement. These successes prove that highly effective change driven by nurse leaders who get systems is entirely achievable.
This context brings us right back to that IOM blueprint.
The Future of Nursing report.
Which provided those 4 core messages, which are, essentially the job description for this transformation.
Yes, these messages are the foundation. Everything is built on them. Number 1, nurses should practice to the full extent of their education and training.
So maximizing their scope of practice.
Exactly. Get rid of the unnecessary barriers. Second, nurses must achieve higher levels of education and training.
Seamless academic progression.
That's the term. It's a push for more BSNs, more MSNs. The AON, the American Organization for Nursing Executives, they call for BSN and MSN as the minimum for nurse leaders.
And doctorates for executives?
And doctorates for executives.
Yeah.
It raises the professional bar significantly.
Okay, what's number 3?
Third, nurses should be full partners with physicians and other health professionals in redesigning healthcare. They have to be at the strategic planning table as equals.
Which demands advanced communication skills.
Absolutely.
Yeah.
And finally, number 4, effective workforce planning requires better data collection and an information infrastructure. You can't fix what you can't measure.
So data mastery is non-negotiable.
It has to be.
So the goal isn't just being a better unit manager anymore. It's being a data-literate, system redesigning, high-level partner across the entire spectrum.
It's a huge professional evolution.
Yeah.
It demands strategic thinking that's far beyond the bedside.
Okay, so if the environment is defined by this ambiguity and complexity, where everything is shifting daily, a leader needs a framework to understand how their organization even functions under that pressure.
They do.
Which brings us to systems thinking.
You just cannot manage modern healthcare using these linear, simple cause and effect models. It doesn't work. Systems thinking is essential because it moves us past the idea of an organization as like a simple machine.
It's seeing the forest, not just the trees.
Exactly. It identifies learning organizations as those that understand how an activity in one area influences all the other elements of the whole.
Right.
Peter Senge, who really popularized this, he defined organizations as complex systems. They consist of people, structures, and processes all constantly interacting.
And the health of the system is a result of those interactions.
Precisely. If you try to pull one lever, you affect the entire machine, often in ways you didn't anticipate. A nurse leader has to see the second and third order effects of every decision.
So Senge laid out 5 disciplines for a true learning organization. And what's fascinating is how they connect high-level strategy right to the leader's own mindset.
They're all interconnected.
Let's walk through those. Where does it start?
The foundation is personal mastery. And this isn't just about being competent at your job.
No.
It's this ongoing effort of continually clarifying your personal vision, focusing your energy, developing patience, and this is critical seeing reality objectively without self-deception.
It's continuous personal growth as a strategic imperative.
That's a perfect way to put it. If the leader isn't growing, the organization won't adapt.
Okay, so after personal mastery, we have mental models. This is all about self-awareness, isn't it?
It is. Mental models are those deeply ingrained assumptions or hidden images that influence how we understand the world.
And how we act.
And therefore, how we act. For a nurse leader, a mental model might be, physicians always know best. Or maybe, change is always painful.
And if those are unexamined, they become these invisible barriers to innovation.
Exactly. Becoming aware of those hidden frameworks is critical because they dictate how you allocate resources, how communication flows, everything.
The third discipline then moves from the personal to the team. Building shared vision.
A core leadership function. It's the practice of creating a collective, compelling picture of the future, something that fosters genuine commitment.
And the key word there is commitment, not just compliance.
That is the key distinction. If your staff are just complying, they're waiting for permission. If they're engaged in a shared vision, they're innovating and adapting on their own.
Which is essential in a dynamic setting.
You need it to survive. Which leads directly into the fourth one. Team learning.
Right.
Team learning starts with genuine dialogue. Senge describes it as the capacity of a team to suspend their individual assumptions, those mental models we just talked about, and to truly think together.
It's a collective cognitive process.
It is. The team's knowledge exceeds the sum of its parts. This is how high-reliability teams function, especially when they're managing these high-stakes, ambiguous situations.
And then finally, the fifth discipline, systems thinking, kind of acts as the glue for all of it.
It is the glue. It's the discipline that integrates all four of the others. It's the overarching framework that connects personal mastery, mental models, shared vision, and team dialogue into a coherent, adaptive whole.
It gives the leader that holistic perspective.
It does. To see how a solution in one department might create a problem down the hall.
Okay, so systems thinking is rational, it's structured, but modern healthcare,
Right.
it often seems to defy pure rationality.
It absolutely does.
And this is where we have to bring in complexity theory.
We have to. Complexity and chaos theory are essential because they recognize that the natural world, and therefore any large modern organization, does not operate based on overly rational, predictable thinking.
They're not machines you can just program.
No, they're complex adaptive systems, or CAS. These are networks of many agents, people, policies, technology that are all interacting, learning, and changing spontaneously.
And when you apply that CAS model, some of the findings, especially from thinkers like Ralph Stacey, are almost unnerving for a traditional manager.
They're very counterintuitive.
What does complexity theory say about our reliance on things like, say, data analysis or long-term strategy?
Where Stacey's work suggests that in a CAS environment, a lot of traditional management concepts just break down.
Like what?
For example, analysis loses its primacy. In a system where nonlinear events are common, just analyzing past data won't accurately predict the future.
So you could spend 6 months analyzing infection rates.
And then a new flu strain or a major supply chain disruption makes that analysis completely irrelevant overnight. Second, contingency, or that simple idea of cause and effect, it loses its meaning. Small inputs can have massive, unpredictable outputs.
So the idea that you can map out a predictable path forward is basically a myth.
It becomes an illusion. Long-term planning becomes impossible, and visions become illusions. You cannot plot a secure 5-year strategic path in a system where technology changes every 3 months and regulations shift annually.
Leaders have to accept that strategy is dynamic, not fixed.
That's the key.
Okay, here's the finding that challenges every management seminar I've ever been to. Stacey suggests that consensus and strong, rigid cultures can actually become dangerous.
Right.
But wait, isn't building a strong culture and getting consensus the goal of good leadership? Why would that be dangerous?
It is so counterintuitive, but think about it this way. A culture that values strong, homogeneous consensus often breeds rigidity. It breeds uniformity and resistance to dissenting views.
So it blocks out new information.
It blocks it out.
Yeah.
In a complex system, the ability to adapt quickly is survival. A strong, rigid culture acts like a shock absorber that's too stiff. It refuses to absorb new information or change course. It prevents the system from generating novel responses.
That reframes the entire definition of what organizational strength even is. So if you can't rely on long-term plans or fixed cultures, how does a nurse leader even generate strategy?
Complexity science suggests that strategy has to emerge organically.
From the system itself.
Exactly. It emphasizes the essential nature of being open to accident, coincidence, and serendipity. Strategy isn't planned in a boardroom and handed down. It emerges from the interactions and learning within the system, from the creative disorder that's inherent to a CAS.
So the leader's role shifts. You're not a commander dictating the plan anymore.
You're a facilitator. You're fostering the environment where these emergent necessary strategies can actually take hold.
That moves us perfectly from the complexity of the system to the necessary adaptability of the individual leader. If the environment is chaotic, the person needs to be rock solid. This brings us to the personal toolkit. What are the core competencies required?
Well, to manage in a CAS, you need practical, grounded skills. The AOS, the American Organization for Nursing Executives, outlined 5 critical areas for nurse leader competence.
And this is the roadmap for career development. Let's go through them.
First, communication and relationship building. This is paramount for being full partners with physicians and others. You have to be able to influence and negotiate.
Okay.
Second is knowledge of the healthcare environment, understanding the operational, political, financial context you're in. Third, core leadership skills, the ability to direct, inspire, and manage high-performing teams.
And fourth, professionalism.
Right, which includes personal and professional accountability and a commitment to lifelong learning.
And then the fifth one, something that was historically less emphasized in clinical roles, business skills and principles.
Exactly. Understanding finance, budgets, resource management, operational efficiency. It's all foundational now. You can't advocate for patient care if you don't understand the business case.
These competencies are logical, but our sources point out a serious organizational failure when it comes to developing them.
A huge failure.
It sounds like we're setting emerging leaders up to fail.
We absolutely are. There's a profound gap in leader development and succession planning. The statistic is painful. 79% of healthcare organizations do not include formalized succession planning in their strategic plan.
Just 79%.
And what's the consequence? Organizations promote an experienced, clinically excellent nurse into an executive role just to fill a vacancy.
Regardless of their interest or potential for that skill set?
Exactly. You promote a great clinician into a terrible leader, which leads to burnout for them and failure for the unit.
That void makes developing that personal toolkit even more urgent. And the number one trait that always comes up in leadership research for nursing is emotional intelligence.
EQ.
EQ is central to survival in nursing. Mayer and Salovey defined it as the ability to perceive, appraise, express emotion, to access and process emotional information.
I mean, a long definition.
It is, but it boils down to understanding and regulating emotions in yourself and in others to guide thought and action. For a leader, it's the lens through which they understand everything. But why is EQ so specifically critical in nursing beyond just being a good thing to have?
Because the profession inherently requires an exceptionally high degree of what's called emotional labor.
Right.
A nurse has to regulate their own emotions, fear, stress, urgency, while at the same time recognizing and responding to the overwhelming emotions of their patients and their families.
It's constant emotional juggling.
It is. So the leader's job is to use their own high EQ to create a supportive environment that helps nurses cope with that sustained stress without completely collapsing into compassion fatigue.
And the research shows that emotionally intelligent leadership actually impacts the bottom line.
Oh, the benefits are substantial and quantifiable. They touch every major metric. You see, improved recruitment and retention, people stay when they work for an emotionally intelligent leader.
Higher nurse satisfaction.
Which directly correlates to better patient outcomes. It fosters healthy work environments. It enhances shared decision-making. It's crucial for empowerment and resilience. An emotionally intelligent leader is the key to minimizing the human cost of the safety crisis.
And speaking of that human cost, that leads us right to the massive challenge of burnout.
And compassion fatigue, something nearly every leader in healthcare is grappling with.
Absolutely.
Burnout, stress, compassion fatigue. They're common occupational realities. Clinicians and leaders, they struggle to find meaning in their work, often because the system itself creates these profound barriers to providing genuinely humane care.
So how do we address this? Organizations are turning to the idea of developing resilience.
Right.
How should we define resilience in this context?
Resilience is seen not as some passive quality, but as an innate developmental process or a skill that you can actively cultivate. And a key concept within resilience is something called dual awareness.
Dual awareness. That sounds intensely demanding. What does that look like on a busy unit?
It's the simultaneous ability to focus intently on the needs of others, the patient suffering, the staff struggling, while being acutely mindful of your own personal reactions to that suffering.
So it's about caring deeply without becoming overwhelmed.
Exactly. It's the guardrail against compassion fatigue.
Our sources track how we've understood resilience through 3 waves of inquiry. Let's map that out.
Okay. The first wave defined resilience as this fixed set of characteristics. Things like hardiness, coping skills, self-efficacy, optimism.
So basically, you're either born with it or you're not.
Pretty much. The second wave saw it as more of a dynamic process. Adversity meets adaptation through learning. You fall down, you learn the lesson, you get stronger.
And the third, more contemporary wave.
The third wave views resilience as an innate energy, a life force within an individual. It's about the internal drive that enables them not just to cope with adversity, but to find meaning in it and engage in these cognitive transformations.
So it shifts from just surviving to actively thriving.
Exactly. And the practical self-care practice for developing that kind of resilience is, of course, mindfulness.
We hear that term everywhere, but what's the specific academic definition that applies here?
We should use John Kabat-Zinn's definition. Mindfulness is awareness that arises through paying attention in a particular way, on purpose, in the present moment, and non-judgmentally.
So you're actively observing the stream of stimuli, the alarms, the conflict, the stress, and just suspending judgment about it.
Right, and I think many people misunderstand it as being passive or just emptying your mind.
But it's an active state.
It is absolutely active. It has 2 core components. First, the regulation of attention, intentionally focusing. Second, the adoption of openness toward experiences, framed by curiosity and acceptance.
And that acceptance isn't resignation.
No, it's the ability to experience situations fully without excessive preoccupation or suppression. You accept the stress of the moment without letting it take over your response.
And the impact is overwhelmingly positive.
It's the fuel for sustainable leadership. Mindfulness-based stress reduction programs show significant positive results that decrease anxiety, depression, burnout,
While increasing empathy, relaxation, life satisfaction.
and even a sense of professional purpose. Investing in mindfulness is investing in the longevity of your best leaders.
Okay, so we've established that leaders need systems thinking, high EQ, and resilience. But here's the problem. You can send a leader to a 3-day course on any of those topics.
And then they go back to the real world.
Exactly. They get back to the chaos of the unit and struggle to apply it. Our sources are clear that education and training alone are insufficient.
That is the critical missing piece. And the key intervention that bridges that gap between learning and practice is developmental coaching.
This is the tool that transforms head knowledge into daily effectiveness.
And achieves demonstrable bottom-line results by focusing on human capital.
So let's define coaching in this high-stakes context. How is it used by nurse executives?
It's a dedicated, personalized tool to leverage an employee's existing strengths and talents. It provides focused support to excel, enhances critical self-awareness, and dramatically improves relationships.
And the most crucial part is that through coaching, leaders develop the capacity to do something in the future
that they simply cannot do today without support. Things like delegation, strategic planning, conflict resolution.
So it's a learning lab. It combines leadership theory with practicing new skills in a safe setting.
Exactly. And it targets developmental gaps that often go completely unrecognized by current feedback mechanisms. An annual review might say improved communication, but coaching gives you the framework to actually do it.
And here's a major point of confusion in healthcare, since the industry has been slow to adopt coaching. It gets confused with performance management. We need to clearly separate coaching, performance management, and performance counseling.
This distinction is vital. Performance management is the basic requirement. It's about ensuring job competence, upholding standards. It's compliance-oriented and focuses on the present.
And performance counseling sounds more serious.
Performance counseling is discipline-oriented. It's for the remediation of a past behavior that failed to meet standards. It looks backward to fix a problem.
So how does developmental coaching differ from those two?
Coaching is fundamentally different because it is future-oriented. It's aimed entirely toward growth and maximizing potential. Its focus is on future behavior changes for greater effectiveness, not dwelling on past failures.
And it's not just for people who are struggling.
No. High-potential emerging leaders benefit the most from this focused investment.
And the coaches themselves. They're more than just facilitators.
They're role models. They're change agents. A coach's greatest influence comes from their authenticity, their personal excellence, their credibility.
And our sources highlight 3 things that determine if a coaching relationship works.
These are the intangibles. First, the coach's unwavering objectivity. Second, their exceptional ability to hear beyond the spoken word, to hear what the learner isn't saying. And third, the development of a deeply trusting, respectful alliance.
Without trust, there's no vulnerability, and without vulnerability, there's no growth.
You've got it.
Now, let's get to the number that makes the case for the CFO, the return on investment. When organizations invest in coaching, what does the data actually tell us about the financial return?
The figures are absolutely striking. The International Coach Federation reported in 2009 a phenomenal 700% ROI for companies that formalize coaching programs.
700%. That's incredible.
And 344% for individuals who hired their own coaches.
Yeah, and another study cited an even higher return.
Yes, another one reported a 529% ROI just from the coaching process itself. And importantly, that figure excluded the benefits from improved employee retention.
Which is arguably one of the biggest costs in healthcare today.
One of the very biggest.
But how does improved delegation or better time management translate into a 700% return? What's the mechanism?
The mechanism is leverage and efficiency. When a nurse manager improves their delegation skills, they stop doing low-level tasks and free up their time for strategic planning.
The very things the IOM demands.
Exactly. When they improve conflict resolution, they reduce the friction that leads to staff burnout and turnover. The saved time, the reduced error rate, the massive cost of retaining one skilled nurse, it all feeds back into that ROI.
A 700% return suggests that effective leadership is the single best way to address that $2.8 billion cost of preventable errors we talked about earlier.
It makes a powerful argument, though we should note the caveat in our sources.
Right, about the methodology.
Correct. While the evidence is overwhelmingly supportive, a consistent, quantifiable methodology is still needed for future research. But the data we have is powerful.
Okay, we've covered the individual leader. Let's zoom out to organizational structure and redesigning care. Given the mandate for partnership and safety, what models are leaders using to redesign how teams function?
We have to start with Team Step PS.
Team strategies and tools to enhance performance and patient safety.
It's a crucial, evidence-based system from 20 years of research. Its purpose is specific: facilitate clear communication and teamwork to drastically improve patient safety.
And the most famous tool from this is SBR.
Right. Situation, background, assessment, and recommendations. It's an essential, structured communication tool. It provides a standard framework to communicate critical info quickly and accurately.
Especially in a crisis.
Exactly. It cuts through the ambiguity and forces clarity.
And how is Team Step Yes rolled out? It sounds like a big commitment.
It is. It's delivered in 3 phases. Phase 1 is assess the need. Is the organization ready? Phase 2 is planning, training, and implementation. And phase 3 is sustainment, making sure the improvements stick.
Beyond team training, the economic and demographic shifts are forcing a physical decentralization of care.
That's the major structural change. Hospitals are no longer the center of the universe. Cost, access, and quality are driving this. Community and outpatient care will increasingly dominate the market.
So nurse leaders need to master leading virtual and dispersed teams.
They do. And that decentralization leads to innovative care models like the medical home concept.
Tell us about that.
The medical home, pioneered by the American Academy of Pediatrics, focuses on coordination. The goal is to provide a continual relationship with a patient and link all their care resources across the entire continuum.
So proactive coordination, not reactive treatment.
That's it. And related to that, we're seeing things like ambulatory intensive care units.
Which sounds like a contradiction.
It does. But it's a brilliant cost-saving measure for those high-risk, chronically ill individuals who incur the highest costs.
So you provide intense management outside the expensive hospital setting.
Exactly. You reduce unnecessary ER visits and hospital readmissions, and the cost savings are significant.
This all seems to be part of the core concept that defines modern healthcare strategy: population health.
It is a radical redefinition of the entire service model. Healthcare is shifting from focusing on sick individuals to maintaining the health and well-being of a defined population.
The goal is to keep people healthy and minimize high-cost interventions.
Right. And our sources break down population health into three interconnected components.
What are they?
First, the central care delivery and leadership roles, usually held by primary care. Second, the critical importance of active patient involvement and personal responsibility.
Population health fails if patients aren't engaged.
It fails completely, which is why the third component is the patient engagement and care coordination programs, wellness initiatives, disease management, things like that.
And the nurse leader is responsible for implementing these across the entire population.
Often using sophisticated data modeling to identify risk and intervene before a crisis occurs.
And we can't wrap this up without talking about technology and the empowered consumer.
Technology has fundamentally changed the power dynamic. It empowers consumers. It leads to personalized medicine, home diagnostics, continuous monitoring.
Which heightens consumer expectations.
Tremendously. They expect care to be tailored, efficient, and delivered on their terms.
Which means the nurse leader's role is shifting again.
Again, increased consumerism means providers have to collaborate intensely with consumers using technology. High-intensity nursing interventions are shifting out of the hospital and into primary care, or the patient's home.
So leaders have to master leading remote teams and connecting with patients virtually.
Absolutely. Clarity and precision in communication are essential when you can't rely on a physical presence.
This has been an expansive journey. We started with that high-stakes IOM mandate. We drilled down into complexity theory, defined the critical personal toolkit, EQ, resilience, mindfulness.
And we ended with the systemic solutions needed to redesign care, like coaching and population health.
The central conclusion seems to be that the personal is now the strategic.
That's it. The success of the organization, its ability to navigate this complex adaptive system, is directly tied to the leader's mastery of their own personal development.
Nurse leaders are positioned to positively influence the entire face of healthcare.
But only if they master both transformational leadership and the chaos of the environment at the same time.
So let's end where we began, with complexity and accountability. The AOM competencies emphasize professional accountability, holding people to results. But we also talk about Stacy's finding that in a complex adaptive system, long-term plans are illusions and strategy emerges from creative disorder, from serendipity.
That leaves the modern leader with a profound final question.
It really does. If you, the nurse executive, are professionally accountable for results, but you must simultaneously embrace the idea that strategy is emerging unexpectedly from a fluid, chaotic system, what does genuine ethical accountability even look like?
A very tricky balance.
How do you balance holding staff accountable for concrete, measurable results like reducing infection rates, while also fostering the learning, openness, and creative disorder required to navigate that same system?
That is the crucial tension.
Yeah.
Managing the planned versus the emergent.
A provocative and necessary thought for a future defined by change. Something for you to mull over until our next deep dive.